This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
For 2022, my name's John Koutsougiannis. I'm a psychiatrist at the Royal Melbourne and the academic fellow at the department. On behalf of the head of department, Chris Davey, who's here, I'd like to thank everyone who's joined us in person at the Alan Gilbert building here today and also via Zoom. This will be recorded and will be available on the department's website. Today's guest presenter is Dr. Paul Cammell. Some of you will be familiar with his work. Paul is currently the chair of the Faculty of Psychotherapy for the College of Psychiatrists and also the Victorian Director of Advanced Training in Psychotherapies. He's a senior psychiatrist both at the Royal Melbourne Hospital and at St Vincent's Health, where he heads the psychotherapy program. He's also a clinical associate professor at the University of Melbourne, as well as a psychotherapist in private practice. He's the author of numerous articles and books, including Reinterpreting the Borderline, which is about personality disorder, psychoanalytic theory, and philosophy. Today, he'll be sharing some of his experiences applying psychotherapeutic approaches in his roles in the public and private sectors as a clinical lead in emergency mental health and post-discharge services. He's also a research lead for a statewide personality disorder service. So please join me in welcoming Paul. Thank you, Paul.
Thank you all very much for having me along, and hello to everyone online. I'd also like to acknowledge the traditional owners of the lands that we're on today. For most of us, that'll be the Wurundjeri people of the Kulin Nation, and I'd like to pay our respects to their elders past, present and emerging, and acknowledge that the lands were never ceded that we're on today as well. So thanks for your introduction, John. So what am I going to talk about today? I think we've got about 30 or 40 minutes, and as John indicated in the introduction, I guess primarily I'm a clinician and a psychotherapist trained in psychoanalytic psychotherapy and other modalities of psychotherapy. And I've always wanted to embed myself in real world context. So I work in emergency department mental health for many years, and currently I'm heading up the post-discharge program here at RMH as the clinical lead, which is called the Hope and Engage program. So I'm embedded in something which is all about kind of acute crisis in a public system. And I'm also involved with this personality disorder centre of excellence over in South Australia, BBD Co, that I spent a number of years with senior colleagues like Jan McMahon, who's a lived experience and carer expert, and she's been on many college boards, and she has an Order of Australia, and Martha Kent, who's a senior psychiatrist, and us and a few other people were lobbying for a number of years to get this centre up and running in South Australia. A bit like the Spectrum service in Victoria has been here for now, I think maybe 30 years. So we've been trying to get something like that in South Australia. And having moved over here 5 years ago, I've got a research portfolio with BPD Co to kind of evaluate what we're doing. So kind of what I'm going to talk about today are these real world contexts where there are unmet needs and complex consumer needs that we try to meet in real world settings, and the role that psychotherapy can play. So I'm going to talk about what happens in Hope programs in Victoria, and I'm going to talk a little bit about what's on offer with a service like BPD Co and how the unmet needs of an area like personality disorder, which we know is very complex and very demanding, can be met with a integrated step care kind of model of care inspired by Professor Bryn Grenier's model over at Project AIR. And we're trying to essentially roll something like that out in South Australia and also evaluate it as we go. So I want to give you a bit of a flavour in a brief talk about those different kinds of approaches and get a sense of where psychotherapy fits into them, which I think is kind of essential and fundamental. So like I said, this is a little bit about me, BPD Co in South Australia, involved with SA Health, involved with the college, and really trying to advocate continually in the Faculty of Psychotherapy that psychotherapy is a core kind of component to psychiatry training. There are trends in Medicare items that see that psychiatrists are more and more playing a consultative role in their work in the private sector, seeing patients once or twice or for medication reviews, but brief reviews rather than doing longer term care. So I'm very interested in advocating for what psychiatrists do once they're fellows, but also what they're exposed to in training as well, and having opportunities, training placements, different experiences where they can experience psychotherapy. So for example, with the HOPE program at the moment, we've got an advanced training placement where the final year trainee can learn some brief modalities and potentially some longer term modalities of psychotherapy. And it can also be a segue for them going into practice as a consultant. And we're doing similar things at St. Vincent's with the advanced training placement there. And around Victoria, just so you know, there's some other placements for psychiatrists at Spectrum and Monash that furnish those kind of opportunities as well. So big on advocating for that. And some of my writing and research has reflected those kinds of preoccupations as well. The therapeutic counter I wrote with Ross Calusi is really about applying psychodynamic principles to everyday psychiatric practice, whether it's assessment, whether it's team supervision, or whether it's engagement in typical service settings like inpatient or community team environments. And reinterpreting the borderline, that's a bit more of a theoretical treatise, which is really indulging in my interest in philosophy and psychoanalytic theory and trying to address the issue of, let me just see if I can get forward a little bit, a critical analysis of the borderline term. So when I was a medical student and I was going through psychiatric training, I was fascinated that there was this diagnostic category where the term used to describe the diagnostic category reflected something marginal or on the margins or the limits. And I was like, why is this people being diagnosed or having an illness that's called something on the margins or the borderline, and what's that about? So I was kind of reflecting on where the borderline term fit into psychiatry, psychology, and psychoanalysis over the past 70 years, and what it says about our diagnostic systems and our clinical practices and institutional practices, that we've got this dominant term in the middle called borderline. I want to riff off that a little bit later and just mention in passing how we're talking similarly about the missing middle at the moment. You know, the idea that there are these people that fall through the gaps, and who are they diagnostically or clinically or epidemiologically? Who are these people? And why are they falling in the gaps? And I would posit, and I think it's very likely that there's a huge overlap between the two. I'm going to show some of the research that we've done to crisis presentations in South Australia, how that reflects that as well. So going back a little bit, bringing psychotherapy into these domains, I like this expression Paul Valéry made, a French thinker and writer over 100 years ago. Everything simple is false, everything complex is unusable. We need to somehow fit into the middle. Simple solutions often don't work, and there's something very reductionistic and false about them. If we get too complex, we get lost in ourselves and we actually don't achieve anything meaningful. So for someone like a psychotherapist coming into real world complex context, what you do for people out of emergency departments, what you do for people that are ping-ponging all over services, not having their needs met, with complex trauma issues or personality issues, what can you do that's actually meaningful and useful for them? So I think this is a nice phrase that kind of captures some of those dilemmas and issues. Here's some of my writing along the way that you might like to refer to afterwards that talks about how we apply it with the transference focused psychotherapy that I trained in under the auspices of Otto Kernberg's institute over in New York. He's really one of the main kind of founders of thinking and psychotherapeutic approaches to borderline personality disorder from the 1960s. And amazingly, he's in his early 90s now and still teaching and practicing. And I was lucky enough a few years ago to train with him. I guess this kind of convergence of psychotherapy and psychoanalytic psychotherapy with institutions in America was the hotbed of where the borderline term came from. So we've got Robert Knight there in the top middle, who was at the Austin Riggs Center. That's where Eric Erickson subsequently was the director, and he wrote about borderline cases in the early 1950s. He was simultaneously the president of the American Psychoanalytic Association and the American Psychiatric Association. We've got down there the New York Presbyterian Hospital, where Professor Kernberg has been a director of mental health services at times, and he's also got a leading psychoanalytic institute. So there's this conversion of service provision in institutional settings and psychoanalysis where the borderline personality term emerged. So I'm interested in that kind of idea. Fast forward to the present day. We're told that borderline patients are kind of complex. They don't necessarily belong in hospitals for lengthy institutional care. They don't necessarily belong on an analyst's couch, you know, what would have been more relevant 50 years ago. So they need complex, individually tailored systemic interventions. And increasingly, we're thinking about stepped care, phase-specific care, individually tailored care to kind of address these individuals need. And there's increasing optimism as opposed to like 15, 20, 30 years ago, that things can be done. And there's been a consumer movement and a carer experience movement that's backed that up. So it's an important time, and it has been for the last 10 to 20 years, to work out what can be done and meet unmet need. So it's an emblematic problem. We know our systems can replicate borderline dynamics and often iatrogenically create borderline problems. We've got the same dynamics of instability, inconsistency, reactivity, and lack of integration that are purportedly hallmarks of the disorder. So we need to make our systems more stable, consistent, less reactive, and more integrated. And there's potential research to back the idea that that actually is cost effective and it leads to improved outcomes. But this kind of research is very hard to do. You know, it's less controlled. It's often in real world settings. It needs longer term follow-up, and there's a lot of complexity involved. But most of the service models of care that have come out reflect this kind of orientation and approach. So the challenge is how to apply it. So just put that on pause for a moment, and let's think about the missing middle as an analogy. And this is our own head of department here talking about the missing middle as a big kind of problem and crisis for us. How do we meet the needs of all of these people that fall between the cracks or fall in the cracks between our state and federally funded systems? And again, we've got the issue of the institutions or the publicly funded state-based services, and we've got what's offered in the psychotherapy consulting room or the private sector consulting rooms. These people don't fit in, you know, they're not in the leafy suburbs, they can't afford the gaps, they can't necessarily wait 5 months for the person available to see them. But similarly, they might have really problematic experiences when trying to engage with the traditional models that public services offer, you know, through their crisis teams, their community mental health teams, and their inpatient environments. So what do we do about these people? So I want to kind of in parallel talk about what BPD-Co is doing for borderline patients and what services like the HOPE program and different interventions in the Royal Commission are doing for the missing middle, and how actually these things might converge a little bit. This has all come to a head last year or the year before. COVID's a bit of a blur. There was this summit where the ACEM, the Australasian College of Emergency Medicine, had this new report, which was really saying mental health patients are languishing in emergency departments. They need beds or they've got nowhere else to go, so they end up here. So there are upstream and downstream problems. Something needs to be done. They shouldn't be in our EDs. And there was a summit of a policy, and it was really used to advocate for more mental health services. And I was involved in the launch of that. And I didn't like the negative messaging of the idea that people are there and they shouldn't be there. And I actually think that's destructive. So the main message I tried to convey when I was at the summit is actually people need lots of access points and places to go to get help. And it might be an emergency department. And if they're in an emergency department, there needs to be some kind of patient-centered, trauma-informed, receptive and non-reactive engagement with the person. And this is particularly relevant for mental health clients and people in crisis, and particularly relevant for people with issues like borderline personality disorder, that people are skilled and comfortable and not phobic about engaging them. So I didn't like the messaging of nowhere else to go, and I tried to counter that. But that's really the sharp end of things, and John might reflect on that as well, that we're increasingly more and more in emergency departments as mental health services, but sometimes increasingly we're seen to be more and more of a problem there, and we should be there less and less. So there's this kind of paradox about putting services in the ED and having a bit of a sink effect, and us all needing to kind of get along. It's a bit like a marriage of convenience, all of us having to get along and work for the client's sake in the emergency department. So, and I think thinking about what kind of dedicated services can be offered and what's meaningful and useful for people is important to think about. So I think the HOPE program and the kind of interventions I'm about to spell out for personality disorder are good examples of what to do. So just quickly, this is a 3-year study I did with a group at Flinders University in South Australia, where we looked at all of the emergency mental health presentations in the state of South Australia, a state of about 1.5 million people. And we looked at the primary diagnoses and different kind of elements of their presentations. And what you'll see here is that primary, what previously used to be called low prevalence or axis 1 disorders like schizophrenia and bipolar disorder are a very significant minority of the presentations. If we've got 30,000 presentations, about 4,500 of them have these issues. Personality disorder, I would argue, is significantly underdiagnosed compared to the international literature. So we've got about, sitting at about 3,000 people in that group, 10% being diagnosed. And we know a lot of research says 25 to 40%. But what's the majority of the people presenting? And I always kind of bang on about this with people. We're dealing with people in suicidal crises or situational crises, 6,000 people with a mixture of mood, anxiety, and substance use issues. There we are, we've got another 20,000 there. So really the majority of people that are presenting have that mixture of, I would argue, characterological or personality disorder vulnerability, suicidality and other forms of decompensation in a situational crisis, and a mixture of mood, anxiety and substance use issues. And this is like, in a sense, the sharp end of the missing middle, and also a lot of unmet need in the personality disorder space. So what we're doing for BPD Co is actually looking at more diagnostic fidelity and how we can trigger, I suppose, through frequent presenters or other warning signs, how to more proactively follow up higher risk groups or higher need groups that present in the state of South Australia in crisis to emergency departments. And I'll tell you a little bit about the acute and brief intervention clinics that are being rolled out across South Australia. We're looking at flagging frequent presenters. And I think most people that work in public mental health services are familiar with the really high risk frequent presenter complex consumers getting some form of enhanced treatment plan or management plan. We're looking at a more systematized, collaborative approach for doing those kind of plans, which involves obviously consumer engagement and carer and other stakeholder engagement as well, and doing it in a systematic, replicable and potentially researchable way. So thinking about what's been happening up until this point for BPD and the missing middle and this kind of group of patients that I've showed identified in that research, there's a lot of challenges in providing follow-up. SA, as I said, has got the BPD collaborative. Now Victoria's got Hope services being rolled out everywhere, and that's important. Previously, Victoria's had the Spectrum statewide service and Centre of Excellence, which offers kind of excellent evidence-based, highly skilled interventions, therapy interventions and secondary consultation interventions and training, but there's limited reach for that kind of service. And that's what we knew when we were setting up BPD Co, that having that kind of hub and spoke model where you've got a centre and people need to go to the centre, there needs to be much more integration and outreach, and in the generalised settings, much more intervention that's rolled out systematically and in a consistent way. So that's not done enough in Victoria. And there's the potential with these new interventions for the missing middle coming out of the Royal Commission to potentially fix that. So here are all of the recommendations from the Royal Commission, and suicide prevention and hope services are right in there. So anyone presenting with suicidality to an emergency department or other service will get specialised follow-up, and that's what I'm involved in at the Hope Service at Royal Melbourne Hospital. If we look at the Royal Melbourne ED at the moment, I think this is last year's data, and we get about 5,000 mental health presentations a year, and a significant majority of them get full emergency mental health assessments, and this is John's purview at the moment, heading up that service. Only a minority of them get admitted, and prior to setting up the Engage service, which is a shorter term, less intensive post-emergency service, and then that was set up in 2016, and now the Hope service, which was set up 2 years ago, there is a significant proportion of them, up to a third of people had no follow-up at all. And often these people were people presenting with anxiety, situational crisis, substance use issues, self-harm or a suicide attempt, and they weren't getting any meaningful follow-up at all. So now the model of care is that all of these people get some form of follow-up, and it needs to be kind of flexible, creative and individually tailored with this broad scope of team. So that's what's occurring at the moment. What we're seeing as well is the numbers of presentations to EDs like RMH are increasing dramatically each year. And if you look at the data, actually presentations of schizophrenic illness, bipolarity aren't actually going up at this rate. It's the majority of people of this missing middle type group that are going up each year, 15%. So it's becoming more and more of a need in the community. So I'm going to keep talking in parallel a little bit about BPD. I've got a lot of slides here and I'm aware I haven't got too much time. So what do I want to really convey out of this is we're trying to think about breaking the model that was around about 10 or 20 years ago, where everyone needed a super specialised therapy, either weekly or twice a week evidence-based psychotherapy that might last 18 months to 2 years, or it's got a combination, a multimodality combination of groups and individual therapy like DBT or day patient programs or potentially inpatient programs. So kind of a one-size-fits-all, or that intensity is required. Actually, a lot of evidence shows that that's not necessarily the case, and there isn't necessarily a correlation between BPD severity and the intensity of the treatment that's required. And there is evidence that shorter term interventions, like the ones I'm going to show you, are actually helpful in reducing symptom severity. So we need to get smarter, more sophisticated, and integrate other shorter term interventions and access points into service provision for BPD. So if we imagine that old way of thinking, imagine in the state of South Australia, we say 4% of people have BPD. So say it's about 68,000 people, or we have the more severe cohort of 17,000 people. All of these numbers below don't necessarily make a lot of sense or are that required. But basically, if we've got a very well-staffed spectrum-like service where people need to come, we might actually be able to provide about 620 patients with intensive therapy compared to the 17,000 in need. And you do those numbers in any context, it's unachievable, and it always will be. So we need more systemic approaches and hub and spoke models with outreach. These are the modern therapeutic approaches to BPD that I won't need to go to in any depth, but suffice to say it's really lots of modalities of psychotherapy that are important. But we're increasingly thinking about systemic responses and integrated responses as well. All of these specialised BPD therapies are pretty comparable in efficacy, and there isn't necessarily this correlation I said between severity, intensity of treatment and outcomes, and some brief interventions can be helpful as well. And this is increasingly reflected in these kinds of guidelines, like the NICE guidelines, the NH and MRC guidelines, and the South Australian guidelines. So practitioners and services can skill themselves in all of these different ways: dialectical behaviour therapy, transference-focused therapy, mentalisation-based treatment, all of those therapies, but also need these more general skills or generic skills as well that are reflected in models like structured clinical management that the mentalisation group have developed, or Gunderson's model of good psychiatric management. So there are these kind of general approaches that practitioners and services can develop to upskill. I'm just going to gloss over where I was training. Dismantling studies can help us a little bit to indicate what are some of the shorter term interventions that can be helpful. Skills training groups that are briefer can potentially be helpful. Sometimes supportive groups without too much specialised input from a therapeutic model can be helpful as well. A mixture of generalist care or good enough management and short term groups can be helpful as well. And equally, so in South Australia, we've got what are called roadmaps, these short-term group interventions, which are a bit of a hybrid of something like skills-based acquisition that you do in DBT with treatment planning, psychoeducation, carer, and other stakeholder engagement, and work with the individual. That's shown in trials like Laporte's trial to be helpful. And we are currently studying the efficacy of a type of 8-week group intervention that we've developed called roadmaps. So that's occurring at the moment. It's kind of reflected on what I said previously. So just what I want you to get out of that is longer term treatments don't need to be routinely prescribed. We want to have that shutting the door in your face kind of situation removed. We want to really convey an idea that people are equipped at any point in primary care, in emergency departments, in crisis teams, and other situations to say something can be done. People feel skilled to already, engage the person in a discussion of the person's issues. If there's a suspicion or a provisional diagnosis that there are kind of personality disorder type issues, and then they're referred to some kind of clinic where this can start to be addressed. So the other arm of this that I really want to talk about before I go back to the HOPE programs are these brief intervention clinics that we're offering. So the aspiration in South Australia is basically anyone who presents to an emergency department or a crisis service or even in primary care, within the week, they can get access to a 4-session intervention. And this intervention involves a mixture of further assessment, crisis stabilisation, treatment planning, and carer and other stakeholder engagement. it's been shown that actually just having a simple intervention like that can be incredibly stabilizing. If you can imagine, if you've ever worked in an emergency department and you've got this sickly feeling that you've got to discharge someone that you don't think kind of needs to be there, you're going to give them a fairly loose promise that they should go and see their GP and book in to see a psychologist, or that they're going to get follow-up with a crisis team and be called, and you're not necessarily sure what they're going to be told on the crisis line, and you've got a bit of a sinking feeling about what's going to be on offer when they leave. If you've actually got a sense that you're in a part of a cohesive and integrated service model where this person's going to get something consistent, they're going to get contact made within 2 to 3 days, they're going to get some information sent to them, they're going to have whoever's in their life engaged with as well as their usual treatment providers. And this stepped process of 4 sessions is going to be on offer. That's incredibly stabilizing and is shown to have good outcomes. So that's what we're rolling out in South Australia at the moment. So these are some of the outcomes from research to date that Bryn Grenier's done. And in terms of representation rates going down, a reduction in ultimate length and number of hospital admissions, and also other kind of symptom measures that are done on scales as well. There's been further research, and that's the kind of research we're doing in South Australia at the moment. We've already had, we're into thousands of people that are accessing it, but it's not fully disseminated across the service. Just a little bit more information about them. And it's this hub and spoke model, essentially, where in the step model of care, where essentially we want consumers to access this, and we're gradually, there's the step care consumer pathway, which is quite complex and hard to read, but basically it begins, you can see in that grey box in the left corner here, with this assessment and brief intervention clinic, where people then might be referred back to the private sector with different tools and things planned, or they might engage in the group therapy programs that we are talking about, or they might be supported case management in the public mental health service, and then there might be access to more specialised therapies, and there's increasing kind of skills building and resource building in the services to offer those therapies like DBT and mentalisation treatment, schema therapy, transference-focused therapy. So it's a kind of a complex nexus of support that begins with that brief intervention clinic. And similarly, for the more severe and complex and frequent presenting, there's a more reactive and more wraparound kind of option of interventions that are involved as well. So the idea is that out of BPD Co, there are hub clinicians that go out to all of their LHNs or local health networks and do these treatments, and by osmosis modelling and training, they upskill the people in these services to do it, and increasingly it grows. And that's kind of 2 years down the track, that's what we're trying to build at the moment. So that's the acute and brief intervention clinic, only 4 sessions, embedded in real world service provision as a part of a stepped integrated care model trying to address personality disorder. So now let's sidestep to talk about hope again. So there's the idea here that everyone can access this. All of the people that used to, maybe a third of people in emergency departments that used to not get much when they left, are now getting some kind of support if they're presenting with suicidality or a suicidal crisis to the emergency department. So they're getting a mixture of clinical and non-clinical staff response, psychiatric review, psychosocial support, brokerage funding, peer support, drug and alcohol input, psychosocial input, and all of these kind of principles behind it. Lived experience is very important. We've got a fantastic lived experience worker in our group. The clinical and the non-clinical are integrated, which I really enjoy, that we've got this group that we all get together and work around the individual. So it's person-centered and strength-based. And from my point of view, it's a very positive kind of experience working in this team, which is what drew me to it. And it's very exciting that these are being rolled out from my point of view. Psychotherapy-wise, a range of brief therapeutic interventions, CBT, ACT, problem-solving skills, solution-focused therapy, single-session family interventions. All of the team are getting trained up in these things and offering these things based on the consumer's needs and preferences. And what we're seeing is that different consumers have preferences for more of the non-clinical engagement or the clinical engagement. I want a psychiatric review. I don't particularly want to talk to those clinicians. I feel more comfortable with the lived experience worker, and we feel it out with the person over 12 weeks when we engage them. And we have rich discussions in the group, formulating and understanding and trying to intervene with these kind of principles behind what we're doing for the people. So it's early days yet. We're 2 years in. We're continuing to kind of evolve and develop our model and our approach. And And obviously, I'm very interested in introducing something like the 4-session intervention for personality disorder into this. So we're looking at collaborative research with South Australia and some training in our group and potentially more widely. And that could potentially overlap with some of the more kind of outreach services that Spectrum are looking at the moment. They've for a couple of years had their PDI program where different services have had clinicians and psychiatrists in those services trying to seed more specialised interventions for personality disordered individuals in those services. So there's potentially overlap in those kinds of approaches. So what I would say, just before I kind of go on, all of these programs need to have a kind of a philosophy or an approach to risk and working with suicidality. And you can just think about, well, we've got this model, we've got this philosophy of how the team's going to work, and we're going to work with individuals and address their situation and their crisis and try to engage them. But you need to have a way of thinking about the fact that the person's presented in a suicidal crisis or even made a suicide attempt and how to approach it. And there's kind of quite a literature on which increasingly dismisses the lack of evidence that certain kind of ways of ticking boxes and assessing risk profiles at an organisational level doesn't necessarily yield great outcomes in the coalface working with individuals. So often having a collaborative approach to assessing and managing and working with the client who's at risk or who's suicidal and trying to focus on engaging contextually with the different factors that are making them in crisis at the time is generally seen to be the way to go. There are different types of, I guess, paradigms that are being researched to kind of reflect that shift or that change in approach to working with suicidality. And this is one of them. This is Pisani's model, working preventatively with risk in this collaborative kind of way and looking at protective factors and different contextual factors that are making the person at risk at the moment. And the reason why we chose this one is it's quite accessible and teachable and transferable amongst the team. It's all of the different kinds of skills bases of the members of the team, including non-clinical staff, can access it and work with it and be trained in it. And it's internationally current at the moment. There's quite a lot of them around. We had a few others to choose from. There are some groups that remain kind of critical of any of these more formulaic approaches, but from my point of view, you need to have some kind of approach to have a coherent understanding of what you're all doing, even if you can see that there are limitations to it. So it kind of gets back to that Valerie's statement about not having something that's too simple that it's false, not being too complex about it that you can't actually do anything meaningful. You've got to kind of have something pitched in the middle to kind of try to do the right thing, even though there might be limitations. I think this model, as a group, as we were planning the model of care in the HOPE team, we levelled on this one as being the most suitable for our needs. So that's what we're using at the moment. So that's the kind of the HOPE program. What I'd say, it's kind of interesting in Victoria, and comparing South Australia and Victoria is quite fascinating. In South Australia, we've had this capacity, we've had the funding to set up BPD Co. We've got some support to try to disseminate it and improve uptake, and we've got the resourcing of the staff to kind of go out and engage with this model of care that I've talked about in this stepped integrated kind of way. What's kind of interesting is there isn't any kind of compulsory mandate for LHNs to take it up. So it's fascinating how many services will, champion it and get on board with it and will really run with it, whereas other services will organisationally be hesitant, dismissive, and reject it. And that's quite difficult. And there isn't like a central Department of Health or chief psychiatrist mandate that thou must do this model of care. So it's involved a lot of diplomacy, a lot of engagement, a lot of attempts to kind of get people on board, which has been quite challenging. What's kind of interesting in Victoria is there is this mandate that everyone needs a HOPE service. Here's the funding. This is the timeline that you've got to get it out, start it, and evaluate it. But there's been less kind of detail or depth in the model of care. So it's kind of interesting. I actually like it in terms of being creative on the spot in our RMH HOPE service. We can get in there and really set up our own model of care and approach to evaluating it. But the criticism I would make is there isn't a lot of systematicity between all of the HOPE services. You have the idea that if you present at RMH, you're going to get one HOPE service experience. If you present at the Alfred or you present at Frankston Hospital, you're going to get a very different experience. So it's not all the same. So all hope services aren't the same. There's lots of differences in the approaches. Creates a certain freedom contextually on the ground to be innovative about what you do. An example of that for RMH, for example, is a significant proportion of people that present at RMH are out of area. You know, obviously, centre of town, you get people that are a significant homelessness population or transient population, or people that are just passing through the city that present to our ED. Hopes, in theory, aren't really meant to treat people that are out of area. We've got a huge amount of patients that present that need some kind of intervention. So we've been able to flexibly kind of mix this older engaged service with the hope service to continue to create kind of outcomes and fashion solutions for individuals presenting, and not just put up walls, essentially, which is a real problem with any service. It's the siloing, it's the inclusion and exclusion criteria, and actually doing things that meet the needs of the service setting and not the individual that presents. So trying to be flexible, trying to offer things. So I'd say one of the positives of having that scope and flexibility is that, you know, all services are different. There are different contexts. So you need to be able to kind of be flexible. So that's the promise of hope, as well as the idea that we can potentially do some innovative and creative things like inserting some of these acute and brief intervention, clinic type interventions for personality disorder, which we're finding impressionistically are very, very common within the cohort that we're seeing with the hope service. So I think it's important to think about that as a specialised type of intervention, because we're seeing a lot of it in the service. So just in conclusion, I'm really trying to model in this discussion where psychiatrists can take a lead with psychotherapeutic roles in these kind of real world settings. And this is our article I wrote with colleague Jackie Amos and Michael Bagent. Michael Bagent, Professor of Psychiatry at Flinders, who's been involved in the Beyond Blue and the types of Beyond Blue and COVID psychotherapeutic interventions that have been offered, modelled on the IAPT, or Improving Access to Psychological Treatments, from the UK, developing those kind of programs throughout Australia. So he's a bit of an innovator and a thinker of how we can do different psychotherapeutic interventions in the public sector. Jackie Amos, child and adolescent psychiatrist and psychotherapist, similarly is working in the NGO space with Anglicare and other groups dealing with very high risk families and mother-infant dyads, doing interventions in that space. So we kind of wrote about what kind of role psychiatrists can play to advocate for psychotherapy in the public sector, and I kind of specify these different roles: being a supervisor, a teacher, a clinical lead, and also having links to your own private work. So it's the other thing I'd say, working in the HOPE program or with BPD Co, is with my hat on as a private practitioner, I know what's kind of going on out there, where people are out there trying to find things, trying to find help. And I think about, well, as a psychiatrist, if I just see people for individualized, intensive, specialized therapy, my book's closed pretty much immediately, and then I'm not available. So I try to make myself available for co-management, second opinions, consultation with psychologists, all of those kind of things as well, and thinking about those roles and how they kind of parallel with what we need to offer in the public sector to integrate things a bit better. So that's probably about all I want to say today with the time we've got. So hopefully there's some questions and some responses or comments. So thank you all very much. Okay, anonymous attendee. What I've observed, that the case management model in Victoria does not align with any psychotherapeutic models. Yeah, I'd agree with that in some respects. That, you know, there's always going to be exceptions to that, but thinking about, often case management and community mental health teams can be very, very generic, and that there is the opportunities with personality disorder or non-psychotic disorder kind of clients to weave in psychotherapeutically informed models of case management. I think RMH and Inner West has done a really good job of that on the ground locally. For example, weaving in Gunderson's good psychiatric management model for some clients that have become community mental health team clients. But the issue there, like in trying to integrate services, is, like I've said, the majority of people maybe with milder or moderate or less severe problems, what are they accessing and where are they going? So broader service integration is really important. Another anonymous attendee said, we are experiencing workforce challenges. We've seen many are leaving community services to join Hope. However, we are not getting much new staff in the Hope team, which means implementation of one new team is, yep. It's very interesting. When Hope was being set up initially, I was wondering a little bit about whether this was service redesigned from the inside out. You know, you kind of put lots of resources into a new thing and atrophy some of the old things and see if you can kind of create this reinvention of a service. And there are other types of, historically, types of new kind of approaches which might try to deal with service intervention like that. Because one of the worries I have with the Hope program is it is increasingly being set up to be all things to all people. So everyone can access it. GPs can refer to the Hope program. This is in the staged approach to rolling out the Hope program. I think stage 3 will be basically anyone can refer to the Hope program, and which obviously is going to be kind of unachievable, and it's going to create all of the systemic blocks and challenges and resource limitations that the current mental health service has. So there needs to be careful thought about how the Hope service gets rolled out, gets developed, gets appraised, and gets integrated into the broader services and works well with them. And we notice that on the ground with our service, how we collaborate with the ED, how we work with the triage service and PACE services, and how we liaise with general practitioners and other people as well. I think that all of those kind of challenges to integration are really important rather than just replacing one thing with another. Then Nicola, you include non-clinical staff, peer support worker and lived experience in the model, but only reference training and upskilling for clinical therapies. What can non-clinical staff such as, I think that's peer support workers do in terms of training and upskilling? Well, we do a lot of different things as a group in our Hope. So like I was saying before with the Pisani model, that's something that we all access. The peer support workers and lived experience workers also have their own groups that work throughout different parts of the service, and they have their own peer and supervisory groups and training groups, but there's overlap, and I think that's really important. So things like the Pisani model and some types of interventions like the family interventions we do, there's collaboration, because obviously the carer person in the team is going to be involved in them as well. So there's team-based approaches to the learning as well. I think that's all. If there's anyone else in the chat that wants to pipe in, please do. Is anyone in the audience that wants to make any comments or ask any questions?
Well, can I ask about the term borderline personality disorder? Obviously, you know, especially on social media, the experience seem to loathe the term.
Yeah.
You know, partly because it's got just a lot of baggage, a lot of history. And I'd be interested to hear a bit more about the issue. You've written a book on it, but I understand it was, you know, termed as being on the borderline between psychoses and neuroses. Which obviously, you know, fairly old terms. Does it matter what it's called, and should it be called something different?
It's kind of, in some ways, we're in an increasingly mental health literate and consumer-driven, not only culture, but health culture. And I think there's different segments. I think there are people that increasingly identify with it in a positive way and do acknowledge that they have BPD issues and that makes sense to them. There are other people that don't, you know, and there might be other paradigms or way of thinking about things. And I think what I've noticed even over the course of my career is people are better and better informed, and they come in more and more with, I think I've got this, rather than, you know, just coming in for an assessment. And I have a dialogue approach, a dialogical approach with people about what they might have or what might be going on for them. And some people identify more with complex trauma. Some people think the whole DSM's a joke and they don't buy into it, and the individual's more important in their complexity. So I'm very respectful of that. And I kind of talk about that in my book. I'm a contextualist. I think about things in a very culture-bounded way. And I think the borderline term is like that. So I'll talk with the individual about what makes sense to them, and I'll qualify what I say about BPD. So I don't think, you know, I've got a little quote from Pierre Bourdieu somewhere, which I kind of like in this regard, which we've come full circle with BPD, where we might think it's this natural phenomenon, you know, and it does actually exist. Every established order tends to produce the naturalization of its own arbitrariness. So it's this idea that we think it exists now, and I'm the expert and I'm looking for it, and there it is. People might say, well, we might have colleagues from the Asian continent that might say, well, we don't see a lot of this here, or we don't see a lot of people self-harming, and we might say, if you look hard enough, it's there, and actually we might be starting to constitute and construct it by our kind of health systems and our way of thinking about things. So I take a much more of a kind of culture-bounded approach to this, and so with the individual in front of me, I try to empower them to find what makes meaning to them and talk to them about it and avoid stigma. So that would be the thing that I'd say. But I think it's got some value as a term, but I also qualify that. Great presentation and overview of the spirit of hope. Thank you. My question is, if we are making a 4-session psychotherapy module, then what would those most likely be covering? Also, what would be the duration of sessions and how would they be spaced? During crisis information processing, Cammell. Yeah, so often these sessions, they might be in parallel. As we know, a lot of people with that are designated as having personality type issues are engaging with lots of services. So there's that paradox of nothing's being done, but actually I'm seeing a lot of people realizing that they're not the right people for me, and trying to subvert that and say, well, actually everyone can do something meaningful and constructive, even if you're seeing your GP or you're going to the ED or you're calling a crisis line or a helpline at night. And in the middle of that, you're having this 4-session intervention where you're trying to, frame things for the person. So you, in these sessions, you're actually kind of assessing things. You're identifying what the person's needs and crisis issues are. You're looking at what system of supports they've got around them. You're educating them about their issues and what services might be available. And then you're engaging in treatment planning. So it's pretty basic stuff. It's not really fancy stuff, but it frames the situation for the person, and it plans some next steps for them, rather than them thinking that there are doors being shut in their face, which I think is really, really fundamentally important. Yep. Dr. Sumitra, in my experience, group therapies are immensely useful for people with personality disorder. I might be biased. Can we think of team who run groups in this is what we're looking at in South Australia with these roadmaps group, having them done in the centre, but also gradually skills building and resource building to have all of the centres outside run these groups. As we know, traditionally, like 10, 20 years ago in mental health services, there might be the odd service that would have a DBD group with a 2-year waiting list, or they wouldn't have anything. What we're trying to make is something that's a bit more easy to roll out, a bit less intensive, and it can be a stepping stone within a step system of care rather than being the final destination. There's a very practical one. How soon can JCU1 directly refer to the HOPE program? Very soon, hopefully, yeah. I can't give you a date, but it's very soon.
Any final questions from the group? Thank Paul again.
Thank you. Thanks, everyone. Thanks, everyone.
That's just mainly to finish up, really. Thanks, Paul. That's a great talk. So we're aiming to have these about fortnightly, and you'll be there'll be some communication about the up and coming ones. We're just finalising speakers, and they'll be available on the department website and be recorded as well. So thanks again for coming, and thanks everyone out there in Zoom land. Thank you.
Thanks.